Good afternoon, everybody, and sorry for the delay. As you can maybe see, we are on campus today. We're having our first hybrid Ion Africa since March 2019. So we just have some technical issue, but we're now here. Welcome everybody who are joining us in person or online. I'm very delighted today to welcome Dr. Maji Debena, who's going to talk to us today. So before I pass the floor to her, a brief presentation. So Dr. Debena is a research assistant professor at the Department of OBGYN and Reproductive Biology at Michigan State University. She is a mental health epidemiologist by training. Her work focuses on access to mental health care for underserved populations, including women, justice-involved individuals, and individuals from low-resource settings in both Africa and the United States. So thank you so much for accepting our invitation and for joining us in person. That's exciting. So the floor is yours.
Thank you for having me in person today. It's a privilege to be here. So.
Now,
is this the right one?
Yes.
Okay. Right?
Yes.
Perfect. So it's a great honor today to speak about a work that pretty much informed my experience here in Michigan. I cared about health equity when I was working in Ethiopia, and I continue to do the same here with people who are underserved, even though they're in the US. So the barriers to equitable access to mental health care for people with severe mental disorders in Ethiopia is this work was part of my PhD dissertation a couple years ago. And I continue to collaborate with folks back home, and I keep talking about it in every space. So to give you a few background, there is a large treatment gap for people with severe mental disorders in most low and middle income countries. The vast majority of people with need remain unhelped, or their service needs remain unmet, even though when the need is known. And when they receive care, the kind of care they have access to is either substandard, or they may not have a lifetime access to any form of medical care or modern biomedical mental health treatment. So people with serious mental disorders, in the absence of care, are mostly prone to serious human rights violations because they are considered to be violent, and they are tied or shackled and kept at home in most places when there is no treatment. And there is a high stigma, they're hidden away. And of course, the impoverishment that comes with being mentally ill and unable to work, or the family themselves trying to take care of them will descend into poverty. In Ethiopia, there was a study from 2009 where almost 90% of people with mental health care needs were not helped. Only 10% of people with schizophrenia had some form of access to care. The rest, 90%, had unmet needs to care. And what makes this really difficult is the existing care is centralized in cities, big cities. And the few psychiatrists and mental health specialists we have in the country are either based in big cities, or they're around in those places.
You want to share your slides so the audience can see?
How do I do that? Okay, can they see it now? Yeah, so the existing services are concentrated in big cities, and this is particularly difficult in a country where 75, 78% of the population is rural, and people have to travel 2-3 days to get to a specialist care. So that model by itself is not working. Got it. So when we talk about severe mental disorders, we're talking about psychotic and affective disorders that would result in enduring and long-term disability. And there's the Mental Health Gap Action Program, the MH-GAP. It's a WHO's framework to integrating mental health into existing primary care settings through task shifting. This means with the current specialist model, that care model is not going to address the pervasive need we have in the country. So we need a renewed approach where people, especially primary care providers, should be able to provide mental health care in their routine practice. So there is a high disability associated with mental illness, and they're stigmatized and they're persistent. There's a long-term nature to it. And there's a commitment towards integrating mental health care into the existing primary care settings. So in my study, what I tried to look at was, so there is a setting where there is no care and a service is about to start. So we tried to look at what anticipated barriers are there, what barriers people anticipate to be there, even though mental health care is locally available. And then over time, we looked at the actual barriers experienced after care has been integrated to existing primary care settings. I tried to look at 3 underserved populations, including women, people living in poverty, and rural residents. So from the literature and from the work done elsewhere, so far, we have a lot of structural barriers, including lack of mental health strategy nationally, and we do not have a mental health legislation, or the existing care right itself is structured centrally, and people still find ways to support each other and social support, and probably having some form of physical proximity to health facilities might help with better access. And there are the supply side factors. Even though the need is recognized, if the service is not there, people are not able to go get the service, the help they need. And like we have healthcare professionals who are not trained to provide mental health care, even when we talk about care at the lowest possible lowest care structure. At the individual level, people have different knowledge and beliefs about mental illness that may potentially impede access to care. They have different explanatory models, meaning they have an explanation they give for what they have, what they experienced or what happened in their lives. And there's the demand side factors, like people, even though they have verifiable mental illness, they may still prefer to seek traditional care or holy water sites, or may not trust the biomedical providers. So all these factors interact in a unique way when it comes to equitable access to mental health care for people with serious mental illness in a primary care setting. So the existing evidence is, it mostly, when we talk about mental health and primary care, a lot of the literature mainly comes from high-income countries. And it's largely from studies that are hospital-based, not primary care-based. And there's a less emphasis on equity. It's basically, here is the care, people came and accessed it, but there's lesser focus or emphasis on who is unable to access, even though care is locally made available. And it's mostly a one-off contact, but when it comes to mental illness, people need to engage with care, people need to be in the system over time, and all those things remain unexplored in the existing structure. And a lot, the Africa data specifically, it comes from epilepsy literature. When we talk about integration and primary care and mental health, much of the evidence we have, even to start off, comes from the epilepsy literature, not accurately serious mental illness. So I have this general research question to explore the barriers and facilitating factors associated with access to mental health care integrated into primary care for people with serious mental illness in rural Ethiopia. And specifically, this involves 3 studies. The first study is the anticipated barriers study, which is about barriers in the absence of care or barriers that people think are potentially hindering access whenever care is integrated into primary care. The second part of the work is the actual contact coverage. After care has been made locally available, who are the people coming in and what are the factors associated with not accessing mental health care, even though it's locally available. And then the final piece of this work involves the experience or the actual barriers impeding equitable access to initial contact and ongoing engagement. So as I said earlier, people come and they engage, but we're not interested in a one-off contact only. We're glad they came, but we want them to stay in care. So what are the barriers affecting their continuing engagement with care? Those were the specific questions. I'll go over each of the studies briefly. So to give you a specific detail about this site, it's a small rural site in central Ethiopia in the Gurage district, in the Gurage zone, in the Sodo district of the Gurage zone. It's about 68 miles outside of Addis Ababa. And at the time, there were no mental health professionals trained, and the service people have access to is referral based, meaning folks will be sent to Addis Ababa away. And there was no inpatient care available. This program, the program for improving mental health care, is an across-country project involving Ethiopia, Nepal, India, South Africa, and Uganda. And I was involved on the Ethiopian side. So PRIME is, at the time, it was working to generate a world-class evidence for the integration of mental health care in primary care settings in selected low-income countries. So it had 3-tier intervention involving the community, the healthcare facility level, and healthcare administration level activities. So in the study 1, this is the qualitative piece of the work. We tried to explore the potential barriers affecting equitable access to a planned new service and a planned new mental health service in a primary care setting for people with serious mental disorders. We interviewed people, we did focus group discussions, we included community health extension workers, caregivers of people with serious mental illness. We talked to community elders, healthcare leaders, religious leaders, and of course, higher level district administrators. We talked to them to just learn what they think would be potentially a barrier even when care is made locally available. So there's the availability piece. At the time of the study, the absence of services was a major factor. People won't come to care because there's no care. And then we talked about if care is made locally available, it would, the financial barrier part, especially the money people spend traveling to Addis Ababa or elsewhere and staying at a hotel, that money would help them access care, but the availability part was a challenge. And then this is a community elder. I like reading out their quotes. So if treatment starts in the district, I can't explain how much happier I would become. Instead of traveling to far places in search of treatment and spending too much money and lose their assets in the process, it would be very good if they're treated here. People go to Emmanuel, a psychiatric hospital in Addis Ababa, and other places, including holy water sites like Shankura. People travel to different communities, regions to receive treatment. So this is someone who is really optimistic about the care being integrated into primary care. And the other theme that was really strong was the issue of affordability and accessibility. inability to pay for treatment. So some of the participants told us, even though care is made locally available, we still may have people who are unable to pay for the care, even though it's locally made available. And some others said, people who are living by the main road or have some geographic proximity may have better access to care because they don't have to pay another money for travel. And the third theme is acceptability and adequacy. How acceptable is the care and what is the adequacy or the quality of care like? Some people, of course, attribute mental illness to some spiritual causes. So if I think my mental illness is a demonic possession, why would I go to a doctor? I will go to an exorcist or a herbalist or someone else. So this was one of the anticipated barriers. And there was quality concern. So people generally tend to question quality of care when it's provided at the primary care setting. And some people may still would want to continue going to a specialist setting elsewhere than go get treated in primary care setting there. But there was a hope. The number of people who were treated and their success stories may promote accessibility of the new service. So the equitable access piece, this is the central theme of the entire study. There was a possibility of differential access. Some people thought we don't have people who are too poor to access care when it's made locally available. And others thought, well, even though care is locally made available, we still have poor people who are not able to pay any money to get treatment. But the health extension workers think urban people, male gender, and having better socioeconomic status will facilitate access to care, meaning rural people, women, and those who come from lower socioeconomic status may still struggle to engage or continue using the new service. And specifically gender-related issues here, some of the people said, well, women may feel like they might get raped on their way to seeking care, so they may not still come even though care is made locally available. And others said perinatal women, like pregnant women and women with young children, and those with physical frailty may not be able to come even though care is locally made available. So these were the anticipated sites. Now I'm going to talk about the actual barriers we looked at when after care has been locally made available. So a few months down, we had trained the people, the new services started, and people started coming to care. And this is a study where we tried to compare the contact coverage of the new service in underserved groups, meaning women, rural residents, and people from low socioeconomic status, and people with physical and sensory impairment. So in the initial hypothesis was, we're going to look at the three exposures, meaning the female gender, the rural residents, and the low socioeconomic status. But from the qualitative work, an additional layer to this work that came was barriers experienced by people with physical and sensory impairment. So we included them as well. So one of the other objective is we're going to look at factors associated with not accessing mental health care after care has been made locally available. And we conducted a population-based cross-sectional study. So the hypothesis is women, people living in rural areas, people from low socioeconomic backgrounds, and people with physical and sensory impairment who have serious mental disorders will be significantly less likely to engage with primary health care-based mental health services. And we sampled almost everyone who accessed care. So among those, the case ascertainment, we had like a house-to-house visit by health extension workers and key informants. And people referred those they think would have probable serious mental illness, and they gave them referral slips. Like our key informants were trained and they were given a referral slip, and they look at symptoms and then they give people a referral slip to go to the primary health care. Then they kept a copy of the referral slip. I would give you a referral slip and I keep my own copy. For those who came all referred, they were assessed by a trained clinician using the OPCRIT. And to look at the non-engaged, the people who were referred but did not come, what we did was we went to the health extension workers and the key informants and collected copies of the referral slip to know who they sent. And then we cross-checked that copy with the document at the health center to verify who was referred and who came or who was unable to come. And then we followed up those who were not able to come in their homes. So the outcomes were, the primary outcome was access to care, whether or not individuals identified to have mental illness by community key informants and health extension workers were able to come to care within 6 months after the start of the new service. Then our exposures were poverty, gender, residence, and physical and sensory impairment. The results, this is the exciting piece of this work. I love to talk about it because in a setting where 90% of the people remain untreated after the service has been integrated into primary care, the contact coverage rose to 81.7%. Almost 82% of the people who were referred were able to come, and 2 people refused, 6 people preferred to continue specialist care. 61 of the referred people did not access, and among who accessed, 85.7% had primary psychotic disorder. So that kind of tells a lot about the referral work our key informants and community health extension workers did. And yeah, about 43% had bipolar disorder or major depressive disorder. This is the flow chart of the study. I'm not going to bore you with that. So comparing attenders and non-attenders. So we have people who attended care and who did not attend. And from the quantitative data, when we compared to them, 22 of those who did not engage still attributed their problem to mental illness. So it's not like people don't know they have a mental illness. They do know, and they still attribute it to mental illness. And the barriers they raised include, some of them thought the problem will get better by itself, and others thought they shared their concerns about cost of treatment. Rural residence was significantly associated with non-attendance. And in the multi-variable model, non-attenders were more likely to reside rurally and have less mental disorder-related disability. This is interesting because people seek care when the condition is more debilitating. Like when the symptoms bother them a lot, they would go and seek help. And those who did not come actually had lesser disability compared to those who were able to come, lesser mental health related disability. And we tried rerunning the multi-variable model with rural residents removed. And in that, we had people living more than 180 minutes walking distance away from the primary health care were less likely to access care. So living 180 minutes away from the health center was associated with not accessing primary care-based mental health care. These are the tables. As you can see, the rural area residence is significant in both models. Here, the disability part, having a mental health related disability is associated with, having lesser disability is associated with not accessing care. 1 point increase in the disabilities associated with more access to care. So this is the final layer, the end to the study and this piece. we basically went back to the people who were identified and were able to engage with care, or those who were identified but did not engage with care. So it's like barriers to the initial engagement as well as barriers to the continuing engagement with care. And we try to explore barriers to initial engagement and continuing access to people with serious mental disorders in Sodo district. This is a phenomenological design. So we went to those who were referred but did not attend, engaged but did discontinued, engaged throughout, and their caregivers and health extension workers. We invited 88 people and we were lucky 70 of those people participated. The non-engagement, engagement, and disengagement component of this work, for those who were engaged, the benefits gained from treatment-motivated engagement with care. So people continued and stayed because they're seeing some changes or reduction in severe psychotic symptoms, or are able to function, and they wanted to keep those benefits, so they continued engaging with care. And for the non-engagers, they spoke of different cultural belief and geographic distance as a barrier. But the key barriers that were recurrent throughout in this piece of the work is we have poverty, we have medication, we have long-term care model, we have the nature of serious mental disorder itself. On the poverty part, it's the most frequently endorsed barrier, even though care is made locally available. And participants in all groups, including those who are engaged, the caregivers, the health extension workers who are disengaged, who did not engage at all of them endorsed poverty as a case. Even though they're engaged, they still had issues with poverty. So there is a fee waiver system for people who are considered to be the poorest of the poor. But the quota system is pretty restrictive, and the application is inconsistent by itself. So most people, even though the fee waiver system was there, still most of the poor people were unable to continue engaging or do the initial engagement with care. Reluctance to request assistance. Mental illness by itself is a long-term illness, and you may seek people, like someone may reach out to people in the first couple of months, and then there is a fatigue, and people may not want to continue bothering others, so they still may not continue to engage with care. And maintaining dignity and unwillingness to disclose poverty was another interesting thing. Poor people still have dignity, and poor people still have pride in themselves, that they don't want to put their business out there and have other people help them. So even though people have needs, they still are reluctant to seek support from other people because of pride and dignity. So here is the person, a male caregiver of a disengaged patient, talking about his experience. He says, I wish the Qualitative, which is the local lowest administration, could issue me a poverty certificate that would have helped me get the injection for half the price. However, even to get the poverty certificate, I need money to bribe them. Forget 25 or 50 birr. For the poor, even raising one birr is tough. So it shows you how deep the issue of poverty and affordability of healthcare is for those who are from low socioeconomic status. And another female caregiver of a disengaged person says, there is no one to help us. I'm shy myself. I do not want to ask people to help me. People tell me to beg others to help him, but I do not want to face people with such a request. I do not want to be seen begging people. So this speaks to the dignity and pride in oneself. There are medication-related barriers, which is the second biggest theme of this work. On the medication part, it's mostly valued and it's the defining feature of primary healthcare-based mental health care. but still unreliable supplies and lack of benefit from medication itself or intolerable medication-related side effects were the barrier. People have access to medicine, that's fine. But if I can't guarantee that I can have this medicine supply each month I come in, it's still a barrier. And the other thing is a lot of the medications were older generation medications with more severe and debilitating side effects. And most people had to discontinue because of the intolerable medication-related side effects. A lot of the Africa literature that comes from the epidemiological data mostly attributes maybe people in Africa may not want to access care because they prefer traditional care as compared to the modern care. But this wasn't the case in this study. Only 2 people who did not engage disclosed their preference to traditional care. Like not everyone we spoke to did not engage because they wanted to continue using traditional care. On the medication-related barriers, the issue of power dynamics was very salient. So here is a person, a female caregiver of a disengaged person talks about her experience. She says, it's a huge deal for me that she had 3 people who she was taking care of. Affected family members are sleeping at home after the tablets. That's enough for me. I do not want to go to the doctors with complaints. What if they deny me the tablets? How can I tell the doctor that their medication did not work? Who am I to do so? So it speaks to the power dynamics between the caregiver and the doctor, or the patient and the doctor. It's like people, especially those who are in long-term care, would need to know their condition, need to go back and engage. But when they see some change, they still are happy with the change. But like this person said, I'm not worried that they will go out or get hit by a car, but the medications are not doing anything else. But I still have, who am I to go and confront the doctor? And this part, the long-term nature of illness, people generally tend to look at prolonged engagement with care negatively. Like I will go to a hospital for a one-off contact, but going to the same facility over and over again for the same illness is not considered positively in the community. Cure-oriented model they expect, and lack of tracking mechanism for serious mental disorders. So in Africa, in Ethiopia in particular, we have a really strong model of tracking people with HIV who disengage. We have a really strong model of tracking people with TB. But when it comes to serious mental disorders, when people miss their appointments or when they don't disengage, the ascertainment and the tracking mechanism is not well developed for people with such conditions. And the other part is support. So few years of diagnosis, people still have strong social support because they can still reciprocate and they still have resources to stay in that space. But over time, the kind of social support one has access to will keep declining, and they can't do much, so they don't get much. So if you're not abiding to the principle of reciprocity, what you can get out of a certain relationship is limited. And multiple comorbidities, people who have serious mental illness, diabetes, hypertension, other issues, that by itself complicated the long-term engagement with care. So the nature of the illness, the lack of flexibility of the existing service was a challenge. So people who have mental illness need to come to the health facility. It's not like the health facility having an outreach to go and bring those people to care or serve those people in their communities. They still have to travel 2 hours or so to get to the nearest health facility. And the issue of violence towards others. People with mental illness, when they try to transport them, they may attack others. So it's difficult to put them in public transportation, and families end up getting overcharged for transportation fare when they try to put such a person on a bus. So that was another challenge. This is a female caregiver of a non-engaged patient. She says, recently we heard that there is treatment at the health center. We rented a car to get him there. My 2 sons were trying to help him board. He beat them both and escaped. So it's like getting the person, the ambulatory care, the kind of support people would need to bring non-engagers to care is limited. This is, so I'm coming to the end of my talk. Just to discuss a few of the stuff I have here in light of the evidence, the current evidence. This study is a systematic study of equitable access to primary healthcare-based mental health care from a low-income rural setting. We did a really thorough case ascertainment that covered almost everyone that was identified with probable mental illness. And the contact coverage was high of those who were identified. 81, almost 82% of the people ended up getting the first engagement or the initial access to care. On the study 1, the calculation of distance, like when a health center was constructed, they talk about, oh, this health center is within an hour distance for everyone, but that 1 hour is like a distance from A to B. It doesn't account for the terrain, like people have to climb hills, people have to go down. That is not considered. So that type of geographically mapping health facilities and placing them is another issue that needs to be considered. And there is a little emphasis on femininity of poverty despite the evidence. So people talk about poverty in general terms, but even when we talk about barriers of women, when we talk about poor, still the poorest of the poor are mostly women, and we need to consider that. The issue of perinatal women at risk of discontinuing treatment was one of the key things in the initial Qual study, and the guideline for referral. So in the MH gap guideline, if a woman is pregnant or breastfeeding, the health extension workers are trained to send that woman to a hospital. They're not trained to manage that type of person locally. So that was another issue that needed attention. The second study, the quantitative study about contact coverage, it was high. Like it's unbelievable that we had almost 82% people were able to access care, but this probably was affected by the fact that at the time of the study, we were also reimbursing people who were able to come because we were also doing assessments related to this study and other studies for those who participated in our study and their caregivers. We did some reimbursement, and that probably motivated their access to care, and more people were able to engage. But still, poverty was not a barrier for initial contact. I'm super careful when I say that, because the initial contact meant people were in for a baseline assessment and were given some money because of the study, and they used that money to buy their prescription and go home. We played when they came back for the appointment, when there was there was, of course, multiple interlinkages of poverty and mental illness. people drift into poverty because of mental illness, or people get mentally ill, people get poor, and poverty by itself puts people through so many adverse events, and that might lead to developing some form of mental health challenges. There's disability associated with that, social exclusion, reduced earning potential, decline in productivity, and catastrophic healthcare spending, leading people they're leading their livelihoods to decline and descend into poverty. Community-based health insurance system, and introducing this might help. If there's a community-based health insurance system that covers everyone, including those with chronic care needs, that may help against the impacts of catastrophic healthcare spending. Supplementing fee waivers with conditional cash transfers. When people talk about fee waivers, still the criteria is erratic and it's not applied consistently, but if there's a cash transfer system, families would still be able to get their prescription. And the issue of social support and affordability, and well, contrary to what's been reported in the global epidemiological papers, still we have people who prefer traditional healers over the biomedical care, but still they were not significantly higher compared to those who were able to get engaged with our care system. So the innovative care model for chronic illness, when people have a long-term condition, it's really not between the patient and the doctor. We need to engage the healthcare system, the policy system, the community system, strengthen the tracking system. All those need to work consistently to lead to proper engagement and continuing equitable engagement with care. And that needs emphasis. This work also calls for minimizing power differentials, specifically on training people who are in long-term care conditions to advocate for themselves, or ways to engage with the doctors, or intentionally flattening the hierarchy within the healthcare system so other people can engage with them. Outreach to address the inverse care law. So the inverse care law is, okay, there's care, but people need that care and they're still not coming. So availability by itself doesn't guarantee access. So those with most need are still least likely to engage with care. Even though we know that there are people who need care, if it does, like availability by itself doesn't guarantee equitable access to care. Yeah, so I will say a little about the strengths and limitations of my study and this talk. It's a typical rural primary healthcare setting, and we used contextually adapted, validated measures. We involved clinicians to confirm diagnosis of primary care workers, and we examined anticipated and experienced barriers from both sides. And we tried to involve the voiceless, like people who would otherwise be neglected. We tried to find ways to creatively engage people with serious mental illness. The limitations part, we tried to look at people who were in the community at the time and who were coming to the healthcare facility. We did not go the distance to recruit people from holy water sites or other traditional healing places outside of the district. We were not able to do that. And because this study is was also reimbursing at the time for participation in the study, we fear that the reimbursement might have inflated the contact coverage. And underrepresentation of women in study one, in the anticipated barriers to study, we had fewer women, but that's because we talked to people in leadership positions, and in those communities leadership positions, including the religious leadership and the community leadership, the elders are mainly assumed by men. Again, in the initial study, the anticipated barriers to study, we did not involve a lot of people with serious mental disorders because there was no care at the time it was difficult to find a person that's not symptomatic and is able to be involved in a study and have a conversation with us. Those were some of the issues. To conclude, we have seen that integration of mental health care into primary care setting in a rural, low-income setting has led to achieving high-level treatment coverage, and the care seemed equitable with respect to gender, physical and sensory impairment, and socioeconomic status. But addressing the needs of people with serious mental illness where rural residents emerged as a priority, because being rural was associated with lesser likelihood of accessing care. And the issue of transportation, if transportation is not accessible, people living outside 180 minutes or more walking distance outside are still less likely to access care. So that needs attention. And above all, more flexible service configuration, not just like opening our doors and waiting for people to come to our health centers, but doing community outreach, having effective case tracking and follow-ups in the community will improve access to care. So yeah, that's the end of my talk.
Thank you so very much, Dr. Debena. And you might see some confusion about the names. Dr. Debena was not able to use her computer, so she's using mine, and I'm using Lisa Frazier. So for people who don't know me, I'm Awasar, and I'm the moderator of Ion Africa, our weekly seminary series. So thank you again, and I'm gonna ask people in the audience here in person if they have questions. I think so.
Okay. Well, thank you so much for this very fascinating talk. It's like a very thorough research. A lot of different levels. Very analytical. I just about the rest of the population, outside this specific region. When I had other sites for treatment that are different in this district. And my concern is the whole fact that whatever institutions are put in this place, specifically particular of mental health, are going to be inadequate even when one gets forward. And it's clear that poverty is a big issue. What is the future of it? Is there any government intervention to try and address that situation? Or maybe some other programs?
That's a really good question. What happened after this study on in that site is based on the evidence generated from our study and from the studies that followed this, we ended up integrating mental health care to all the districts within that zone, the Gurage zone. But beyond that, right now in Ethiopia, we have inpatient facilities, again, still limited to cities, and outpatient clinics in all the regional teaching hospitals. And we still have primary care-based mental health care in selected parts of the country, but it's not uniformly applied. It's a work in progress, I should say, and there's a lot of hope. We have the National Mental Health Strategy coming to effect around 2012, and it got renewed again. So we have a working national strategy and plans to ensure that mental health care is being integrated to all primary health care facilities nationwide, but I still say it's not uniform, and when it involves primary inpatient care, it's still not equitable.
We have a question here. Somebody wants to know, government, if there is any focus on training home-based caregivers, and also if there is a way to integrate practical healthcare with modern healthcare to create more of a hybrid.
That's perspective because I'm hopeful about the traditional care people helping with the. So one of the things we did in this work was we trained traditional healers to refer people who come to the modern, the environmental care, to the care and health facilities. And from those we trained, well, of course, we had that tracking mechanism where we collect all the reference lists of people. When we checked the referral pathway, those still came from our informers and community health workers. None of the traditional healers we trained sent anyone to us. So right now, the Addis Ababa University's psychiatry department has an outreach to health to a holy water site around Addis Ababa, and they do that work, I know, and that's been their outreach work for a couple years now. But when we talk about traditional healers, honestly, it needs more than just like the talk of engaging them, because it's also a livelihood for them. When people go to them, they pay them, in some cases way higher than what they would have paid in primary care facility, because the primary care health workers don't promise them cure, they promise them recovery. And the traditional healer tells them, oh, it's complete cure if you do XYZ, and you have to bring this and that, and people throw their money, their livelihood into that in pursuit of healing. So I understand it's a strong resource, but it needs to be carefully considered when we talk about long-term care models. I think the question had another side. Regarding training home-based caregivers, family members, yes, I strongly believe there are ways we can engage them. And part of the implications of this study is involving family members to, developing interventions that are delivered by lay providers and can improve engagement with care and improve outcomes and reduction in symptoms for these people. But again, it's another area that needs to be explored based on the results of the study. There's no ongoing piece of work that I know of, but I'm hopeful, and I believe it's a missing piece that needs some work.
Sure.
Yeah, go ahead.
My question is multi-pronged. First, how do we go about defining mental health? And is there some kind of range of issues that we should be identifying when we talk about mental health? That's I guess my overarching question, and it goes into my next question about the cultural component of mental health. To think of what culturally sets like Ethiopia apart from like South Africa or some other place. When I think of South Africa, I think of like historical trauma.
Yeah.
And I think of historical trauma, and I think of historical violence, and how that kind of feeds into some mental health issues. And so how do we talk about mental health, particularly with Ethiopia? And then when we talk about mental health, I gather here in the US, we talk about the stigma, especially in African American community. We talk about the stigma of having these kind of discussions of mental health. And so I'm just wondering, how do some of these issues kind of settle in Ethiopia or even some of the other case studies?
Yeah. So on defining mental illness, for this particular study, we looked at people with psychosis or severe mental disorders. that have long-term and enduring disability. We limited this to people with schizophrenia, people with bipolar disorder, and people with major depressive symptoms, disorders with psychotic symptoms. So if they didn't have any psychotic features, they were not involved in this study. But speaking of mental health situation in Ethiopia, how distinct it is from elsewhere in Africa, I think we can, well, as someone who is trained in Ethiopia and is currently working here in Flint, Michigan, when it comes to health equity, a lot of the things are transferable. Like those people I know have difficulty accessing care in Ethiopia, may not be those exact people here, but when it comes here, it's people with like history of like other trauma and maybe some adverse life events linked to that. But the underlying situation is poverty is the biggest determinant of social health, the biggest social determinant of health, and addressing poverty in whichever setting has the capacity to improve livelihoods and to improve mental health outcomes for people. With African countries, I understand the impact of colonialism and how it played in terms of like lack of trust to medical care, and how it created mistrust between healthcare professionals and people who need this care. When it comes to the US, it's the legacy of slavery, because people have, like, it's not too long ago, really. It's like the African side is 50, 60 years ago, and like countries, when like, yeah, about 86, it's everything happened within the past century. And when it comes to the US, it's like we're still dealing with the legacy of slavery, and people still know uncles and grandparents who were slaves, and that the trust component, it still is a big part of lack of access or barriers to care. In my work with women in Flint, one of the recurrent things is the fact that people have been betrayed by systems, or people have been let down by people who they trusted to take care of them. So it's complicated in some way, but when it comes to equity, there are some underlying features that are common and cross-cutting.
Wonderful. So we have a question here. I think it will be better if you read it. Yeah.
This study goes to leaders. So we talked to like religious leaders, district level healthcare administrators, and we talked to elders from the community, and those roles are traditionally assumed by men in that community. We had some women, but they were very few. We didn't have enough women because of the patriarchal structure of the community. Okay. Which one is it? Question, sorry. Oh, the medications part. You mentioned that there were huge problems with medications. Is that due to
No.
No?
Sorry, we just have some technical difficulties here with trying to log in. Okay, now you're in again. Yes. So just unmute yourself.
Where's the question? Can you read the question?
Yes. But you're muted right now. So the question is, you mentioned that there were huge problems with medication. Is that due to errors in diagnostic or the manner in which medications are administered? What needs to change with how medication is administered so that the benefits clearly outweigh the pain costs associated with them? Do you know if the efficacy of traditional medicine is being studied by African researchers?
The medication part, it's not that part that's the challenge. It was the lack of options. So if one medication does not work for someone, or if the side effect from one medicine is intolerable, prescribers don't have much options because a lot of the medications they have access to are older generation medications with much more debilitating side effects. And when patients find it difficult to continue taking them, they usually stop using them. It's not like the administration part, it's more like the side effect part that's intolerable. There were times, like for someone who used to take the pills, to switch back to the injections, it's much more costly. And the injectable medicine is not really accessible for most people. It wasn't at the time. So that it's factors related to the supply side, and the side effects that are more debilitating are the reasons why people had issues with the medicine. There was a Can you read it? The final question.
Is there a way to integrate traditional healthcare with modern healthcare?
Yeah, definitely. People still, I believe, people still have resources. I strongly believe in being locally available, to be able to hear and research information, people with disabilities. And I think there are multiple avenues to engage with people that it needs carefully designed and tested ways to develop interventions that work with the school.
Well, thank you so very much, Dr. Debena. This was exciting to have in person. So we thank you very much. And everybody will see you next Thursday. Bye.